Welcome to this video tutorial on the spine examination. So for the spine examination, you are still going to use the mnemonics look, feel and move. So you first look if there is any spine abnormality, if there is any spine deformity, you look. If there is any spine deformity, like in the case of a thoracic kyphosis or a lumbar lordosis. The patient can also change position, can get assisted in order for you to better appreciate, and other abnormalities like scoliosis, you can visualize it. The next element is to feel. You try to feel the different spinous processes, and you should have landmarks in order to feel the spinous process. The best landmark to feel the spinous process is at the level of the cervical prominentia. The cervical prominentia, which is the major spinous process at the level of the base of the neck, is the C7 spine. So directly above the C7 spine is C6, and directly below is going to be T1. So that is how you palpate at each of them, T2, T3, T4, T5, T6, and then you can go downward to the sacrum. If there is any tenderness at each of these sides, it means that the patient can have an abnormality of the nerve or the vertebra at that level. The next thing is also to do some small percussion. Percussion can also reveal any tenderness or inflammation of the muscle. The next thing after that part which is feeling, you now need to move. Can you sit up? Can you sit up? To move the spine, you ask him to flex the neck. Please, can you bend the neck? I saw you see you have flexion of the neck. You ask him to extend the neck. Please, can you extend like this? So you have extension of the neck. You ask him to laterally rotate as such. You can ask him also to flex the back. Please, can you flex? You see he's flexing the back. Can you extend your back? He's capable of extending the back. So all this, you see that there is no abnormality. And normally, you have to first start active motion before you go up to passive motion. That the patient has to do it by himself, and then you do with the patient. So I'm now going to help flexion. I'll do extension, I'll do lateral rotation, I'll do flexion of the thoracic part, and then I'll do extension of the thoracic part. So there is no tenderness. The next thing in the spine examination is going to be the neurologic examination of the spine. For the neurologic examination of the spine, you have to assess the dermatome, the myotome, the reflexes, and then the suanal reflexes to visualize if there's any spinal shock. For the dermatomes, you can start from the different prominences directly inferior to the cervical prominence. You need to know that one. For the cervical nerve come out above their corresponding cervical vertebrae, while the thoracic nerve come out, and the other nerves come out below their corresponding vertebra. So the C7, what comes out inferior to the C7 is going to be the C8 fiber. So here you're going to have the C8 fiber. Ask him, can you feel here? Can you feel here? So you ask him. If he says yes, it means that there is no abnormality of the C7. You can continue directly inferior to the other part. Another point that you have to know is that there are different landmarks of the vertebra on the skin. Here is going to be the location of the C4 dermatome. Here is the location of the C8 dermatome. Here is the location of the T1 dermatome. Here is the location of the C5 dermatome. Here is the location of the C6 dermatome. And here is the location of the C7 dermatome. At the level of the nipple is the location of the T4 dermatome. At the level of the xiphisternum is the location of the T7 dermatome. At the level of the umbilicus is the location of the T10 dermatome. At the level of the suprapubic region is the location of the T12 dermatome. And similarly, you have dermatomes of the lower limb. Here is the L1 dermatome, the L2 is the middle third, the L3 dermatome is the inferior third. Then you have the L4 that goes up to the toe, and you have the L5 that takes up these other fingers, and then lastly you have the S1 which is medial and S2 which is lateral and goes posterior. So those are the different dermatomes. The next point are going to be the myotomes. So to evaluate the myotomes, I'm going to show you in mnemonics. You need to know that what? The mnemonics is the mnemonics of a child, a playful child, for the upper limb dermatomes. For the mnemonics of the upper limb dermatomes, you need to know that what? For the upper limb myotomes, you need to know that if a child is already capable of notching, if you are capable of doing flexion of the neck, it is for the C2, C3 fibers. If you are capable of doing lateral rotation, is a C4 then myotome. If you are doing elevation of the neck, is a C5 myotome. If you are doing flexion of the elbow and extension of the wrist, is a C6 dermatome. If you are doing a myotome, if you are doing now flexion at the level of the wrist, is going to be the C7 myotome. If you are doing flexion at the level of the fingers, is a C8 myotome. And if you are doing abduction at the level of the fingers, it's the T1 myotomes. So those are the different myotomes involved. And you are going to have their different significance, particularly in Erb's palsy and Kumke's palsy. In Erb's palsy, you have C5 and C6 abnormality. That's why the positioning is as such. C5 and C6 are absent. While in Kumke palsy, you have C7 and C8 abnormality. That's why the positioning of the hand is as such. So those are, you're going to see it later on. Now the next thing is to evaluate the myotomes of the lower limb. L1 and L2 are used in hip flexion. L3 and L4. L3 is used in hip and the knee extension. L4 is used in flexion at the level of the ankle. L5 is used in extension of the big toe and also inversion. S1 is used in flexion at the level of the So you have to know that the L5 is used in plantar flexion or flexion at the level of the ankle. Then S1 is used in flexion at the level of the knee, and then S2 is used in extension at the level of the hip. So those are the different movements for the myotomes. After that, you have normally the next part that you have to do to evaluate for the spine examination are the reflexes. For the reflexes, you must do the reflexes of the upper limb, you do the reflexes of the lower limb, and all the like. Now, the last aspect of the spine examination is going to be the DRA. For the DRA, you have to evaluate for the bulbocavernous reflex, and then in the bulbocavernous reflex, what you do is that you pull the gland of the penis while your finger is inside the anus. You're going to feel a contraction on the anus. For a female, you pull the urinary catheter while your finger is in the anus. And then if there is a positive bulbocavernous reflex, it is normal. In a case where you have an absence in bulbocavernous reflex, it means that there is a spinal shock. The last